I'm Dr. Diva Boone of the Southwest Parathyroid Center, and in this Facebook Live, we're going to talk about what to expect for parathyroid surgery. If you did miss it, I recorded the whole summary of parathyroid surgery and the different types and what I do on a separate video, and that is on YouTube now. I've gotten better about uploading all the videos to YouTube. Okay. So let's get into what to expect for surgery. This is mostly going to be me just chatting here because it's the kind of the easiest way to cover it. I know when you're having an operation, it can be nerve-wracking for any operation, any procedure, because any procedure has its risks, and going into it, it's probably the first time you've ever had it done, and so you don't know exactly what to expect. So I want to kind of get into that, make you feel a little bit more at ease. Parathyroid surgery is, it tends to be one of the easier operations to recover from. So it's typically going to be, well, I try to make it as good of an experience as possible. It is an operation, but most people can get through it safely and not have too much of a bad time with it. All right, so what do you expect? Now, I went over what I do for operations, and so most of that's going to cover, I'm going to cover basically what I do and what I tell my patients to expect. If you have a different surgeon, it might be a little bit different, but it'll probably be pretty similar because, you know, the operation, there's only so many different ways that this operation can be done. Most of it, especially before the operation and after the operation, is going to be similar. Okay, so what actually happens on the day of surgery? Well, for my operation and for pretty much every operation out there, you're going to be asleep for the operation. So you're not going to be awake. It's not very comfortable to have somebody digging around in your neck and be awake for that. It does cause you to cough, especially if you have to go around the trachea. So it's general anesthesia, so you're asleep for it. That means that before the operation, you have to treat it like any other operation. So the night before, you're going to be no eating or drinking after midnight, and you're going to meet the anesthesiologist right before the operation, usually like a few minutes before. You talk with the anesthesiologist, they go over everything. The anesthesiologist is going to be with you the whole time, just like the surgeon's there. In the operating room, there's potentially more people than you expect, and you'll meet a bunch of those people. But the anesthesiologist, sometimes there's a CRNA, which is like a nurse anesthetist as well, an OR nurse, which is the one kind of overseeing everything, sort of outside, not operating. And then you have at least one tech, which is the person standing with you at the table. So when you go into the operating room, sometimes it can seem like there's a lot more people than you expected. And that's okay. That's pretty normal. There's at least one anesthesiologist, one OR nurse that is circulating, not scrubbed in, meaning not at the operating room table, and one OR tech or nurse that is at the table with you, standing with you, the one that hands you the instruments, that kind of thing. And then sometimes there'll be other people, like another nurse, another tech. You'll meet all those people before the operation. There'll be a stream of people. And like any procedure at any hospital, they're going to confirm again and again things that you've already answered. So you're going to have to say your name and your date of birth. You're going to have to say your allergies multiple times. This is all really standard stuff. It can get annoying, but again, we don't want to make the mistake of operating on the wrong person or giving you something you're allergic to, so you have to answer those questions a bunch. With my patients, so some of my patients come in and they get the scan, the sesame scan, the morning of surgery. If that happens, you go for that first. It's about half an hour. Then you meet me in the pre-op area and I go over everything. Again, some of the stuff I've already told you and some of it's new, but I go over the same stuff with every patient. And most surgeons will do this, and I go over what I expect post-op. Some surgeons won't actually, but the best practice would be to go over all the post-op instructions beforehand. So I like to do that before you're sedated. If I tell you about your post-op instructions after the operation, you're not going to remember anything. You might remember some of it. You're going to forget a lot of it. So I go over it beforehand. I go over what to expect afterwards. I go over how much calcium to take, and that's the big thing after surgery is you need to take calcium. And I go over the risks of the operation, and the risks are pretty minimal. I'll get to that in a minute, but I go over that all before the operation. Make sure I've answered all your questions. You go back to the operating room. A lot of times you may not even remember being in the operating room. Actually, if you get good anesthesia, a lot of times the whole thing will be a blur. So you'll be wheeling back to the OR and you'll wake up in the recovery room and you won't remember most of what happened. What does happen in the operating room is you're on a stretcher and you have to transfer to an OR bed. The anesthesiologist then is going to put you to sleep. Typically that means, giving you some medication through the IV. If you're getting general anesthesia, which is what I recommend for everyone, actually, then you get a tube that goes in the trachea that protects the airway throughout. That's actually the safest way to do this operation, and it's what I recommend for everybody. There are other options. The other main option is an LMA, which is a laryngeal mask airway, which is like a big plastic thing that you sit in the back of your throat. It doesn't go quite into the trachea. It's kind of right before that. It's not quite as safe as an endotracheal tube, which is that tube that goes into the trachea, and it actually closes the trachea off, so nothing like your mouth, saliva, that can't get in there. Nothing can get past that tube. With the LMA, it doesn't protect the airway as much, and it can be easily dislodged if you're operating. So I really recommend endotracheal intubation for everyone. That's what I would do for myself, and what most surgeons are going to do. Okay, so you get that. You actually don't remember it. You're pretty much already mostly asleep by the time that goes in, and you're awake, and it comes out before you're awake. So you don't remember it. You may have a little bit of a sore throat from it, but you won't remember it going in or coming out. And then after the operation, like I said, you wake up in the recovery room. Initially, you're not going to be very aware of what's going on, but usually by about half an hour after the procedure, after getting to the recovery room, most people are awake, talking. By about an hour, you're able to get up, sit to a chair, and usually by about an hour and a half or 2 hours after, we can let you go. We're not going to shove you out the door. If you're still having issues or problems, you hang out with us. Or if if you're having nausea, something like that, we want to get that under control before we let you out. But usually on average, about an hour and a half is a good amount of time. By that point, we can let you go safely. You're not going to feel perfect afterwards. So I don't expect you to, wake up from surgery and then skip out of the hospital feeling perfect. No, you're going to be tired. Expect that your body just went through something. You're going to be tired. You're going to be kind of groggy and sore, and you're probably just going to want to go home and rest. And that's normal. Most people will go back home, take a nap, and they're good. Some people will go out to dinner for that night. Most won't. And if that's not you, if you're not out going for a dinner, going for a walk on the beach, that's okay. That's typical. I expect most people to just take a nap when they get back and take it easy. I always call my patients the evening of surgery. So somewhere between 7 to 8:30 is usually when I call. And I call and I'm just checking in. Most people by that point are kind of feeling a little bit better. Things are starting to resolve. If you don't remember talking to me after the operation, because again, I do talk to everybody before I let you leave the hospital. The nurses in the recovery room know that they cannot let you go until I've talked to you. So I make sure I see you before you leave. And usually by that point you're awake and you remember what I say. But just in case, I call you that night. If you had questions that you didn't think of till you left, then I can answer those then. And that's the day of surgery. So it's outpatient. You're not in the hospital. You stay with us usually for a couple of hours or 1.5, 2 hours after the operation, and then you can go. The total time you're in the hospital is longer because, again, hospitals usually have you arrive well before your procedure so that you can be all set up. And then, sometimes it's not uncommon to arrive 2 hours before your actual scheduled procedure. And remember, that gives us time to do the scan, which is about half an hour. It gives us time to get you set up, get the IV in, get you changed, talk to everybody, meaning the surgeon, you'll talk to me, you'll talk to the anesthesiologist, you're going to talk to the pre-op nurse, you're going to talk to the OR nurse. There's a whole lot of people who have to ask you the same questions about your allergies again and again. But we have you arrive ahead of time so that we can get all of that done. So the total time you spend with us, I tell people, plan on spending half a day with us. The actual operation is less than an hour. So you're in the operating room for less than an hour. You're not going to remember any of it probably, but you're in there for a short period of time. Okay, so that's kind of the day. If you have questions about that, put them in the comment section and I will answer them. But one of the big questions, big things people want to know is, what are the risks of this procedure? Because like anything, it has risk. Every procedure you have done, getting a dental cleaning has risk. I mean, everything has risks. And there are risks to this. It is an operation. Generally, it's very, very safe. So most patients will go through this without any real problems. There are some kind of side effects of the operation that are the biggest things that people might notice, but the actual big risks of it are pretty minimal. So there are two things I tell people about, two risks that I'm looking out for that I want to make sure don't happen. One is bleeding. And with this, I'm talking about bleeding after the operation. So when you're in the operating room, whenever if you cut yourself, you get bleeding, right? So when we're operating, when we're opening things up, there is going to be some bleeding. There isn't usually a lot of bleeding with this operation. So typically there's not a lot of blood loss, but afterwards the tissues are still irritated. I mean, when I close the neck afterwards, there's a little incision that's all closed up with these sutures that are absorbable. And there's no bleeding when I leave the operating room. You wouldn't leave the operating room if there were any bleeding, but the tissues are still very sensitive at that point. And if you can have some bleeding afterwards. This is with any operation. If it happens in the neck, fortunately, it's very obvious because your neck swells up. It's really not a subtle thing. If you just have a little bit of puffiness or a little bit of soft swelling, that's totally normal. But if you get bleeding, usually it is very soon after the operation. Like we say, the biggest risk is in the first 6 hours, and then every 6 hours after that risk goes down. So usually it's that first period right after the operation. And if you would notice a lot of swelling, typically, it won't be subtle. A lot of swelling, it'll be big, hard, painful. It's noticeable. I tell people, because this happens very rarely, right? It's well under 1% of cases, pretty uncommon. But if there's any question, you have my cell phone number. Every patient of mine has my cell phone number, and I want you to just call me immediately if you're concerned about something. And you have time. Even if you are noticing a lot of swelling, you've got time to call me. Sometimes it's just normal swelling, and that's okay. And I tell people, just take a picture, text it to me. I'll take a look. If there's any question, I will bring you into the ER and so that I can feel your neck, or I'll meet you at your hotel room sometimes so that I can feel your neck, so I can make sure and just reassure myself and you that everything is okay. But I do want to know about it. But that's what I'm looking for, is lots of swelling right after. And like I said, typically it's that night. This is the main reason why I have you stay in town the night of surgery. So when people come in, if they're flying in from another state, I tell them to come for 2 nights, the night before surgery and the night of surgery. And the night of surgery, I don't want you flying out the day of surgery. 1, you're probably not going to feel like that, like doing a lot of traveling the day of surgery. But 2, if there is anything like bleeding, and it's rare, but if there is bleeding, then I want to know right away. And someone asks, is it more likely if you're on blood thinners like Eliquis? Absolutely. So one of the risk factors, there's a couple of risk factors. Big one is if you're on blood thinners. If you're on anticoagulation, that increases the risk of bleeding afterwards. And this is why we do want people to stop their blood thinners before surgery if possible. So if you can come off your Eliquis or your Xarelto or Coumadin or whatever you're on, if you can stop it ahead of surgery, then I want you to do that. Not everybody can. There are some conditions where you really need to stay on it, and that's okay. I've done this operation with people who are on full anticoagulation. We have to change things a little bit, and I'm a little bit more, careful and wary of bleeding, looking out for it, but it's doable. But if possible, stop that. And the times that you stop actually varies with medications. So some you only have to stop for 2 days, some it's 5 days. But we do want you to stop those. If you have any question about that, you can ask your doctor, the person who prescribes it, or your surgeon. Things like aspirin as well increase the risk of bleeding. Sometimes, if somebody has a reason to be on aspirin, Sometimes you'll have to stay on it. But if you can stop your Aspen, if you can stop your Plavix, ideally stop those ahead of time. And then you'll restart them usually the day after surgery because, again, the risk of bleeding is at highest in that first day. Okay, so that's the bleeding risk. Again, uncommon, but I want to know about it, want to look out for it. And the other risk factor, by the way, for bleeding is if you've had prior surgery, the tissues are a little bit different. And so there's a slightly higher chance of bleeding in that situation. If you've got if you've already had an operation there, we have to go back. Again, still very low risk, but it's there. If you have kidney failure, like you're on dialysis, you have a higher risk of bleeding. There's a few things that give you a higher risk of bleeding, but with all of this, even it's still pretty low. And somebody asked about coughing. So patients are always worried, after surgery, whenever you have general anesthesia, you have a little bit more mucus production and your lungs need to fully expand, which means often that you need to cough. It's not uncommon to have to cough a little bit more in the days after surgery. And one of the things people worry about is, if I cough, am I going to damage something? Am I going to rupture something and cause bleeding? No. Now, having very high blood pressure after surgery that is not treated does increase the risk of bleeding. So if your blood pressure is really, really high and not being treated, and it stays like that for hours, that can increase the risk of bleeding. And certainly if you're really, really straining, that can increase risk of bleeding. But if you need to cough, I want you to cough. That's best for your lungs. You're not going to break anything. Your risk of bleeding is not going to be higher unless you're, really just coughing nonstop. So I want you to cough. I want you to do that. If you are coughing nonstop, you can take a cough suppressant or something like that. But in general, coughing is safe. Go ahead and do it. Even retching and vomiting is safe as well. It's very uncomfortable, but it's safe. And if you have to vomit, you have to do it. That's another side effect of just surgery, is feeling nauseated. Okay. Other risk of surgery, the other big thing that I'm looking out for is a change in your voice. And that's a risk because you have these two nerves. They run on either side of your thyroid. They control your vocal cords. They're called the recurrent laryngeal nerves. And you got, again, one on each side controlling the vocal cords on that side. I try to avoid these nerves as much as possible, and for the most part I can, but they do run right behind the thyroid. They do run right along the parathyroid, and sometimes the parathyroid tumor is stuck to that nerve. And sometimes it can be stuck over a couple of centimeters to that nerve. I have to carefully separate them. So I have to be gentle with it, have to take my time, but you can carefully separate them. And usually when you do that, for the most part, you can avoid any injury to that nerve. So it doesn't like being manipulated, but usually it works just fine. You wake up and you're talking normally. Every once in a while, that nerve will be a little bit too irritated from that dissection, from that manipulation, and it will stop working temporarily while that nerve is healing. And what that does is give you a very soft and hoarse voice. It's unpleasant, and sometimes it can give you difficulty with swallowing. It can make your voice hard to hear. You're not completely silent, but your voice is often very soft. All right. This typically resolves on its own, but usually it can take about 6 to 8 weeks for that to resolve. On average, that's what it takes. It can take even longer, like up to 6 months. Fortunately, this is a very rare complication. Again, well under 1% of cases. So not a huge risk, but it's something I'm always looking out for, something I'm always being very careful about. And the best way to prevent this is just to have an experienced surgeon. You may hear something like may hear about a nerve monitoring, and I'll explain what that is, only to also say that I don't do that, and I don't really believe in doing it for most parathyroid operations. What happens with this is you've got these nerves, and you have the nerves here, and with nerve monitoring, they can put a special endotracheal tube in, and it's got sensors to sense the vocal cords. So the vocal cords, when you talk, they contract. And this tube has sensors right there. So when they contract, it'll make a noise like beep, beep, beep. So when you're having the operation, normally those are not contracting, right? They're relaxed. But if I zap the nerve with a little probe, if I give it a little bit of of electrical impulse, then that will activate the nerve and cause the muscles to contract. So I can zap the nerve and get a boop, the sound from the machine. What does this mean? Well, it means that if the nerve is cut or injured, right? If the signal stops, because the signal's coming from here up to the muscle here that's causing the contraction, right? So if there's a damage to the nerve here, and I put the signal here, and I don't get the sound, that means somewhere along this, the nerve is damaged. It's not working properly, right? Okay. Here's the thing about this. You can only tell after you've damaged the nerve. So it doesn't help you to not damage it. It just tells you after the fact that you have a damaged nerve. And to test the nerve, you've got to fully expose the nerve, which puts it at risk. If you can avoid the nerve, that's the number one thing you want to do to prevent any injury. If you start to strip it, meaning take the tissue off of it so that you can see it, so you can start zapping it, you're actually putting it at higher risk. So the best way is not to use this machine, because this machine doesn't prevent injury. It just tells you after the fact that it happened, which you would know soon enough anyway, but it, it's during the operation you can see, oh, it's busted, and what they'll do is they'll keep zapping it. Zapping the nerve's not really good for it either. So I really don't agree with doing this. I think that for most operations, what you want to do is go in there, you want to use what you know of anatomy, and you really should know the course of the nerve, where it's going to go, what it looks like. And if you see something that looks like a nerve, don't mess with it. Keep it intact until you know for sure whether it's the nerve or not, and then be careful around it. And if you do see the tumor and it is stuck on the nerve, that probe is not going to help you, because you can already see that it's stuck to the nerve. You know that. You need to know how to go around it, how to dissect it carefully. The best way, again, is just to have somebody with experience. That's the best way to prevent a nerve injury. But like I said, you can't always do that. There are going to be tumors that are really stuck to the nerve. Then you have to do a lot of dissection on it. Again, the probe's not going to help you. It doesn't help you dissect it. It just tests the nerve. You're going to have to do that dissection regardless. And the nerve, like I said, doesn't like being manipulated. There is always a chance. There's always going to be a time when that nerve has to be manipulated a little bit too much during the dissection, and you're going to have that soft and hoarse voice. But it is going to get better. It gets better on its own once that nerve fully heals. And the key thing about this with the nerve injury is it usually doesn't get better slowly. So it's not like each day your voice sounds a little bit better. That's not what happens. It sounds terrible for about 6 weeks, and then like overnight, it's better. Because that nerve is either working, giving that signal, or it's not. And until that whole thing heals, that signal won't go through. But then as soon as it all heals and the signal goes through, your voice is back. And it takes a couple of days to get back to perfect, your regular voice, but it's not like it's going to get better each week. So that can be kind of disheartening when it happens, but just know that it's going to take some time and then it's going to come back kind of quickly. We do give it 6 months to come back, because sometimes it takes that long. If nothing improves after 6 months, then you want to see an ENT doctor about it and take a look in there, see if anything else can be done. There are procedures that can be done if the nerve doesn't start working. Again, these are all incredibly rare scenarios, thankfully. Even having the temporary nerve palsy is very, very rare. So well under 1%. It does happen. It is a risk of surgery. Again, you can't eliminate all risks, but it's very low chance. Okay. Other things that can happen. So other uncommon things that, you might look out for. One is sometimes you get an allergic reaction. So you can get an allergic reaction actually to the soap that we use on your area, and you can get an allergic reaction to the glue that we use to hold on the tape. And And if that happens, typically you're going to see that soon after surgery. The tape issue usually occurs within a few days, and you'll notice it'll be like a classic allergic reaction. You'll have redness and itchiness, and the treatment there is to take off that little piece of tape and wash the area and put some Benadryl and cortisone on it. Yeah, and then those are sort of uncommon things. Infection is very uncommon. The neck tends to be a pretty clean area, so usually you don't get a lot of infections afterwards. But if that's going to occur, typically it'd be more like 5 or 6 days after surgery that you would notice something like that, and you would notice redness and firmness. Same thing you'd see with any infection, fever, that kind of thing. And again, you would just let your surgeon know. Everybody has my cell phone, because if questions come up, I would rather you just call me or text me than go to the ER or go to an urgent care where they haven't dealt with this very much and don't really know what to do for you. I encourage people to just call me with any questions like this, because usually for most things, I can kind of solve it pretty quickly. Okay, so those are the big risks we're looking out for. The ones I'm especially looking out for are bleeding and nerve injury or voice changes. But I have to mention, with a parathyroid operation, 2 things that are unique risks. One is you won't be cured. This can happen. I have a very high cure rate, so it's about 99% for first-time operations, which means that there will be some people who are not cured with the operation. It's uncommon, right? Most people are going to come away cured, but sometimes you're not. And that can happen for various reasons. I try to minimize that risk because I do look at all 4 parathyroid glands. So that gives you the best chance to get a long-term cure, but not everyone will be cured that way. Sometimes there are parathyroid glands that you can't find. There can be parathyroid glands that are down in the chest that didn't show up on scan. And you may have a second parathyroid tumor that isn't seen because it's in a weird location and it's smaller than the other one, the other parathyroid tumor you took out. So there's always that issue. There's always a chance that you're not cured. And usually that's pretty clear, because if I didn't find a parathyroid tumor, that would be clear. Or if your PTH level, rises after surgery, that would be indicating that you possibly aren't cured. And then there's finally a risk of recurrence. We wouldn't really know this, but there is always a risk that the disease could come back later. This risk is minimized by looking at all 4 glands. Most of the time when somebody's not cured, it's because the surgeon didn't look at all 4, and they may have removed the biggest parathyroid tumor, not looked at the others, and then down the road, the levels kind of get a little bit better, but they're not great, and you're not cured. That's a recurrence when you're sort of cured initially, but then later, or the numbers look kind of good initially, and then 6 months later they're not. The big thing usually is that the surgeon didn't look at all 4 parathyroid glands, and that's why it came back. But you can also have part of a tumor left behind that can come back years down the road. If you have even a tiny remnant of the tumor, you can look cured for years, and then 10 years down the road, that little thing has grown and now it's causing problems. So there are a lot of reasons for recurrence, and that's kind of a separate topic, but that's always a risk down the road. Another risk, especially if you have to have a subtotal parathyroidectomy, meaning 3.5 glands removed, multiple glands removed, there's a risk of hypoparathyroidism, not having enough parathyroid tissue to be able to regulate your calcium. I am extremely paranoid about this one because hypoparathyroidism can be just as bad as hyper, not something I want you to deal with. So I am really careful about this. I look at all 4 glands. I want to make sure that I'm leaving in at least part of one before I leave, and I'm going to make sure that it looks good and looks healthy and alive before I take out the other parathyroid glands. So I do that. I also mark, the one that I'm leaving in, as I mentioned before. I want to mark it so if we ever need to find it again, we can. But I really want to make sure that it looks like it can survive, it can regulate your calcium before I do anything to the others. Okay, but hypoparathyroidism is a risk. If that happens, you end up, like I said, not having enough parathyroid hormone. means that you have a hard time keeping your calcium up and you have to take lots of calcium supplements. Okay, I think I've thoroughly covered the risks. It is a very safe operation in general, but everybody wants to know what the risks are. That's it. Those are the risks. Most people are not going to have that happen. You're going to have a pretty uneventful operation afterwards. You're going to be a little sore, but you're going to be able to talk. You're going to be able to eat normally, and your calcium level is going to normalize. Now, after the operation, what to expect? Here's the next thing people want to know about. When, right after surgery, when you take out a parathyroid tumor, everyone is going to have a temporary hypoparathyroidism because that parathyroid tumor has been making a lot of hormone. The other parathyroid glands, the normal ones, are actually suppressed. So they're asleep, essentially. They're dormant. They have to wake up in order to do their jobs. And initially, right after the operation, they are not awake. This is why, if you check the PTH about an hour after surgery, it's typically in the very low range, like in the suppressed range. Why? Because the other glands are suppressed. They have been suppressed by the high calcium. So when that PTH level drops immediately, when you take out that parathyroid tumor, that PTH, which is really high, it's really high because of the parathyroid tumor. As soon as you take that out, the PTH plummets because those other glands are suppressed. They're not making much hormone. That means that everybody is going to have a drop in calcium. And so it's a temporary hypoparathyroidism that leads to that initial drop in calcium. And the big thing after surgery that everybody needs to look out for is that drop in calcium, and that can cause symptoms like numbness or tingling around your fingertips, or numbness around your mouth, or cramping in your hands or wrists. That usually doesn't happen initially because the calcium can take a few days to drop. So in the hospital that night, you're not going to feel these symptoms just yet. If you do feel numbness or tingling, it's probably actually from the anesthesia. But in the day or two, or usually 2 or 3 days after surgery, you might notice that drop. That's when your calcium level's dropping the most, and you may feel that numbness or tingling. You may need extra calcium. So one of the big things I go over with people before surgery is you have to take calcium after surgery. You have to, because if you're cured, your calcium level is going to drop. So I start everybody on lots of calcium and vitamin D right after surgery. And then if you get the symptoms 2 or 3 days later, you have to take more. You can take a lot. So 3 days after surgery, if you start getting symptoms, you start taking calcium, you can take as much as you need, like the whole bottle if you need it. There really isn't a maximum amount. Now, I do want to know about it. So I tell everybody, if you're taking a lot or it's not getting better, or you're not sure what's going on, just give me a call because I'll talk you through it. I'm really just going to tell you to take more calcium, but I can reassure you that what you're feeling is normal, and I'll talk you through exactly how much to take that day and the next day, and then how to taper off, because you'll usually be able to taper off a little bit later, but you're going to have to take a lot of calcium for a few days typically, and then we kind of do a very, very slow taper. All right. Okay, so that's the big thing to expect afterwards. As far as things like pain control, most people don't need things like narcotics, and actually I avoid narcotics because I don't want them causing the nausea and vomiting that can happen with narcotics, because if you start vomiting, it's very uncomfortable on your neck. The things I do for pain are typically Tylenol and ibuprofen, alternating or at the same time. It really doesn't matter, but doing both of those is good. And then an ice pack, and the ice pack is kind of key. They give that to you in the recovery room. It's a refillable one, but you can use, one that you buy from the store that you put in the fridge. Any of those are fine, but use an ice pack, especially the day of surgery. And then after that, as needed. Okay, so that's kind of what to expect afterwards. I also expect you to not feel great in the first week. This is huge. I think a lot of patients, they go online, and there's a select group who posts their experience online. And that group there's two groups, right? Either you had an amazing, great experience, the best experience of your life, or something terrible happened. So when you're reading about different accounts online, remember that there is this selection bias, right? So the person posting probably didn't have just a meh experience, right? They either had this amazingly great experience or they had something terrible happen. So when you go online, sometimes people will ask me about this stuff. So they'll say, well, I read this person, they woke up from surgery, it was like the clouds had parted, the angels were calling down from heaven, and it was amazing. That's probably not going to be you. Sometimes that does happen. Sometimes you wake up and you feel amazing and seems like your symptoms are gone. Your bone pain goes right away initially, and your brain's clearer. That does happen, but it's not the case for most people, unfortunately. I wish everybody was like that, but usually it's not. It's usually you feel kind of crummy the day of surgery. I mean, you just had an operation. You're going to feel like somebody punched you in the throat. It's not the most pleasant experience. We try to make it, as pleasant an experience as possible, but it's a procedure. And then in the days after surgery, your calcium is dropping and you might actually feel worse. So some people will say, oh, the day after surgery, I felt great because that PTH has dropped and the calcium still hasn't dropped that much. But then 2 days after surgery, that's when that calcium is really starting to drop and you feel it. Your body doesn't like big changes in electrolytes of any sort. So that big drop in calcium, even if your calcium is now normal, might not feel right to you. And that is true for that first week. So I tell people, don't expect to feel better in the first week, or you might actually feel worse. So if you feel worse 3 days after surgery, that's okay. That is totally normal. It is going to get better, but get through that first week and then you'll start to see improvements in the symptoms, typically after that first week. So most people will start to notice improvements, within the first week, but definitely 2 or 3 weeks out. That's when you're going to start to notice that you're feeling better overall. And it usually continues. So one thing people want is that, once it improves, they want it to kind of snap back to normal. And that's not the case. And from talking to a lot of patients, it's usually not like that. What more often happens is you notice improvements, week 2, you start to feel better, you're less tired, you're sleeping better, but it continues to improve in the months after surgery. So you don't snap right back to 100%. Your body has likely been dealing with parathyroid disease for years, right? So it's not just going to snap back to the way it was. It needs time. There is a process in recovery. It is not a, snap your fingers and you're better. It's a process. Your body's got to readjust. But for most people, it does. And usually within a few months out of surgery, people are feeling much better. A lot of their symptoms are resolving. So I tell people to kind of look out for that. This is why I tell everybody to take a week off work. It's not because your neck needs time to heal. Your neck is going to be okay. It's sore for a couple of days, but that's not the main reason. The main reason I want you to stay off work is because that drop in calcium in the first week means that you may feel just kind of bleh, like you may be more tired, more weak, a little bit, just off. That's normal. Take a week off work. Don't force yourself to go in and work. If you want to go to work before that, if you want to take off a few days and go back to work, that's absolutely fine. Some people are fine with that. I've had people go back to work the next day, but it is definitely not what I would recommend. If you can take a week off, take a week off. And then I don't want you doing any really heavy lifting for about 2 weeks. Things like moving furniture around. If you're in construction, take 2 weeks off. You'll get a note for that. But don't go crazy at the gym, that kind of thing. Take it easy for 2 weeks. The main thing there is that it does increase the risk of bleeding if you're bench pressing or you're playing rugby or something like that. We want to be careful with your neck in that first 2 weeks. Okay. So I think I covered what to expect and what to expect after surgery and the risks. If I didn't cover anything, please ask in the comments, and I am going to try to get through all of these now. Okay, so, all right, so Carol asks, can I have surgery if I have IPF? I assume you're talking about pulmonary fibrosis. No, this is tricky. So most people are healthy enough to undergo surgery. If you have significant pulmonary or cardiac disease, you have to get cleared by a cardiologist or a pulmonologist. And they'll kind of give us a sense of whether you can undergo surgery or not. I've operated on people who had significant lung disease and heart disease. It just needs to be cleared by the pulmonologist. But there's no condition in which we say, no, you absolutely can't ever have surgery. It just means you've got to be evaluated. They've got to assess you. And the main thing is there anything they can do to improve your pulmonary function or your cardiac function now, before surgery, that would allow you to have a safer operation? Because it's really all just about assessing what your risk is and saying, can we do anything to change this? So if you've got heart disease, is there something we can do beforehand, a new medication, or even prehab, where you kind of do an exercise program to kind of build up your stamina before surgery, things like that. Is there something you can do to change the situation, make it a little bit safer? Our goal is to have a safe operation, minimal complications, and get you out of the hospital, ideally that day, if we can. Okay. So Mike says, as you know, I'm 2 years post-surgery. I was on 6 Citracal Max. And my PTH has been on the low side for a while. The normal. Went from 6 to 4, and calcium dropped from 9.5 to 9.4. A drop from 9 to 9.5 to 9.4 is actually not like any sort of difference. It's the same number, because there is a margin of error with this test. So 9.4, 9.5 is kind of the same result. He instructed me to drop to, this keeps jumping. Drop from 6 to 4. Go to 3 and then to 2. My endo had me do labs. I wasn't comfortable with a fast drop. Calcium dropped to 9.0. Okay, that's definitely a little bit of a drop. And you're back to 4 a day now. Sorry. Appointments tomorrow. I figure it's a good time to check in. Okay, so your vitamin D is good. It's 62. Oh man, hold on. I have to change this so it stops jumping around. Okay. PTH is 28. That's great. 24-hour urine is 448. Okay, so here's a problem. Mike, and I don't think I realized this with you. So your urine calcium is still very high. And if the urine calcium was 448 while your blood calcium was 9.0, and I'm not sure what your blood calcium was that day when the urine calcium was 448, but that's too high. Now, before surgery, we expect the urine calcium to be really high because your blood calcium is high, it's spilling into the urine. But if at this point, if you are taking lots of calcium and your calcium's in the low 9s and your urine is that high, that looks like more like renal calcium leak. So maybe send me an email because that would be that'd be more of an issue of possibly needing medication to treat that, because I don't like to see your urine calcium be that high. Everything else looks good. I mean, the calcium of 9.0, even a 9.4, 9.0, there's usually fine. There's a range. Most people are in kind of the mid to high 9s, but some people are in the low 9s, and that's okay. With the PTH in the 20s, vitamin D at 60, that's great. But the urine calcium is the more concerning part because it's a little bit too high. So we may need to address that. Okay, send me an email. All right. Okay, Heather asks, can you discuss recovery times and calcium supplementation? How long does it take to feel like calcium is not tanking? Okay, this is important. So when it happens, so when you need extra calcium, it can be quite disturbing. And it happens, like I said, usually it is, right after surgery. You notice it kind of 2 or 3 days after. That's most typical. That's when it starts. It can be really bad, and it can get worse for a couple of days before it gets better. So, meaning feeling like your calcium is tanking, it can feel bad, like you notice the numbness and tingling, you feel jittery. It can make you feel anxious because it kind of creates like an all-over jitteriness. That's usually bad for a couple days and then starts to resolve. Now, if you don't take enough calcium, it'll kind of prolong it, but usually you can get it under control just by taking a lot of calcium, and taking a lot is usually for a few days. So a couple of days, expect to take a ton of calcium, and that may mean 10 pills, 15 pills. You may be taking a lot. But after a few days, it starts to turn around in most cases. Sometimes it can take longer, but usually in that first week is when we can get that under control. And if that's not working, then let your surgeon know, and they may be able to give you like sometimes we'll give a prescription vitamin D to kind of help things along, but to help get the calcium to stop fluctuating as much, but definitely let your surgeon know. Okay. All right, Terry says, I'm gathering records for a consult regarding a redo. The first operation was in 2018. The surgeon retired and closed his practice. Okay, I've had 5 different places, including the hospital. Called 5 different places, unsuccessful tracking down the records. Yeah, so it's often when you have a reoperation, sometimes it can be really hard to get the records. From 2018, though, you should be able to. The surgeon's office was unsuccessful. That's a little strange. The operative report, we're required to keep operative report. We're required to keep all records for a certain amount of time, but I guess 2018 is past when we are required to keep them. No, it's not a problem. I've done lots of reoperations where we don't have the records at all, where there's no records. If it's been over 10 years, I usually expect that we're probably not going to be able to get them. So it's not that uncommon. If your operation was in 2018, you can't get the records, that's fine. Give us what you have if you have notes from that time. Sometimes they'll sort of mention what was done. But if not, that's okay. I'll ask you what you remember of it, what you were told, and I'll try to piece it together based on that. It's like a logic puzzle, but usually I can piece it together. So yeah, it doesn't prevent you from having another operation. Okay. Okay, I think it's Carla asks, I'm 32, had a baby 2 years ago, had high calcium at 14 while pregnant. No doctor mentioned this being an issue. Now, 2 years later, it was diagnosed. High calcium, high PTH, low vitamin D. I'm not sure if I'm feeling symptoms or if I'm just a tired new mom. They recommended surgery because of my age. So your calcium was 14 while you were pregnant? For a second, I thought that was your age, but that was only 2 years ago, so that doesn't make sense. So you're 14. That's really high. Okay, so you're probably feeling the symptoms of this. Being a new mom is tiring, but so is a high calcium. And the risks of not getting it, well, there are lots of risks to not treating this. So with parathyroid disease, it tends to be a disease that causes problems over a long term. So a long period of time, over decades. It may not cause many problems for you right now. I suspect some of your symptoms are related to this. But in the short term, other risks, if you're planning on having more kids, having a high calcium does increase your risk of miscarriage or early labor, which can threaten the baby. So miscarriages are much more common when you have a high calcium. Now, you went through the pregnancy and that was fine, and your baby's fine, but there is a risk to you and the baby if your calcium is high. The other thing, and possibly bigger risk long term, is that it's going to cause symptoms typically, and it's going to cause damage, and it can cause things like kidney stones, cardiac arrhythmias, high blood pressure, osteoporosis, fractures. It causes a lot of stuff, and it can cause you to feel miserable. So I would recommend getting it treated sooner rather than later, especially if you are feeling exhausted. I wouldn't just blame that on being a new mom. I would get this treated. Okay. Pamela asks, oh wait, sorry. I don't know why this really jumps around. It's kind of annoying. Okay, so Pamela asks, do you need surgery if your numbers are high but you've had a gastric bypass? Would taking medications address the issue? I've had the scan, 3 glands long. Okay, so it's important with the gastric bypass. A gastric bypass causes parathyroid disease, but it causes a certain type, which is secondary hyperparathyroidism, not primary. It does not cause primary hyperparathyroidism. And we went over this in prior videos, but the distinction between primary and secondary is very easy to distinguish. You can distinguish these two conditions very easily, because in primary, the calcium is typically high, or at least on the high end of normal. With secondary, the calcium is usually low or on the low end of normal. That's the big difference. So if you've had a gastric bypass and your calcium level has been low, like in the low 9s in milligram per deciliter for years, and your PTH level is rising, that's secondary hyperparathyroidism. If, on the other hand, your calcium level is high, like above 10.0 milligrams per deciliter or above 2.50 nanomoles per liter, whatever it is, then you have primary hyperparathyroidism. Very different. You can have a gastric bypass and get primary hyperparathyroidism that is unrelated to your gastric bypass. So that's the big distinction. So yeah, if you have primary hyperparathyroidism, you need to have surgery. If you have secondary hyperparathyroidism, now that can be treated with supplementation and like calcium and vitamin D, sometimes medications, but that's a different issue. Primary has to be treated with surgery, whether you've had a gastric bypass or not. Okay. Rita says, how do I make an appointment without a referral? I had one removed in 2018. Symptoms went back. Surgeons said he had too much scar tissue. My numbers don't indicate that it's there. Oh, sorry. But that's the way it was the first time. So this is tricky. Whenever I'm dealing with a reoperation, and again, this is a slightly different topic because reoperations are very nuanced. Not like every reoperation is a little bit different. But one, you can make a referral no matter what. I don't require a referral. So you can refer yourself. You can go to my website. You can apply to become a patient, and I'll review all your stuff. That's pretty easy. I don't care about somebody sending you. But your numbers don't indicate. It's kind of weird. Have your numbers normalized? Like, do you have normal calcium and normal PTH? If so, maybe the symptoms are not due to the parathyroid disease. Sometimes I get patients who, the numbers don't indicate they're there, but that means the calcium is high. The PTH is low. Like, if your numbers are the same as they were beforehand, then it seems like you probably did have primary hyperparathyroidism. So I'm kind of confused by this, but regardless, you can always come and see me. You can always, reach out and I'll look at your numbers and see whether it looks like it or not. Sometimes doctors call things normal that aren't. So if you're saying, oh, my doctor said my calcium was normal, but it was actually 10.2, well, that's not really normal. But you have to diagnose this with labs. If your labs are exactly the same as they were pre-op, there's a couple of things. Either you're not cured or this isn't primary hyperparathyroidism and we're dealing with something else. So that would require a much more in-depth evaluation. Okay, Deborah says, I'm 77, my parathyroid tests are elevated. Endocrinologist told me my age would make surgery dangerous. Okay, so if I don't get surgery, what can happen? So there's no age cutoff, and really this operation is very safe even in your 90s. I've operated on many patients in their 90s, and they do great. They do perfectly well with this because it is a safe, quick operation. You're under anesthesia for less than an hour, so you don't get the same anesthetic complications. And most people, even well into their 90s, will go home the same day. There's no problem with that. So age is not really a factor. If you don't get it treated, unfortunately, Deborah, all the things I said can happen. I mean, your bones can get worse, your kidney function is at risk, kidney stones, cardiac arrhythmias, GERD, and just feel unwell. And so unless you're on hospice care, like your life expectancy is very, very low, there's no reason why we wouldn't do surgery. Again, unless you had really severe heart disease. But again, then you just need to see your cardiologist and get that assessed first. But most people can have this operation. Okay. Pamela said, what do you think, what type of doctor is right for this operation? The key is experience. So both an ENT doctor with an ear, nose, and throat and a general surgeon can perform this operation. I personally come from a general surgery background. So I did general surgery training a long time ago. And then I did endocrine surgery training. And then 12 years ago, I started just doing parathyroids. So my experience in parathyroids is very, very high. My experience in doing other general surgery procedures like appendectomy, taking your appendix or gallbladder out, I haven't done that in over a decade, so you don't want me doing that. So it doesn't really matter whether your surgeon is a general surgeon, ENT, or something else. What matters is how much experience they have doing this operation. So I'm very experienced at parathyroid surgery. I'm not experienced in any other general surgery area. But I am still by definition a general surgeon, not an ENT, but ENTs can often get that experience too. It's really just who has the experience with this. Some ENTs don't do thyroid and parathyroids very often. And if that's the case, you don't want those. But if you have somebody who does a lot, that's what you want. Okay, Patricia asks, how common is repeat surgery? Well, like I said, so my cure rate's very high, but in certain situations, the cure rate will be much lower. If your surgeon does not look at all 4 glands, then the cure rate's going to be lower than if they look at all 4. And a repeat operation would be necessary in those cases. What I do, I get a lot of reoperative cases, so I get a lot of people who are not cured, who had surgery somewhere else. So that means that a little bit over 10% of my cases are reoperations. It doesn't mean that they're especially common. It means that I get those patients. So how common is repeat surgery? Not common to need it. If you have a very experienced surgeon, the cure rate's going to be in the high 90s%. So not very common, but it does happen. And I get a lot of these reoperations, but usually they've done focused operations, or the disease has come back. Okay. Carla asked, my surgeon is using the vocal cord nerve monitor. Is it possible to ask him not to? Okay. Here's the thing about surgeons. Whatever they're comfortable with is what they should do. So if this guy is very comfortable using the nerve monitor, then I wouldn't change things for him. I know surgeons who use the nerve monitor, and they're good surgeons. Do I think it's necessary? No. Have I told them this? Yes, but they do it anyway. And for some surgeons, it's more like a comfort thing to know that you can test it if it's there, and they don't always, a lot of times they don't even use it. They just put it in, but they don't really even do the nerve testing. So in general, I would see a surgeon that does things the way you like. If you don't have a choice, but you otherwise trust this guy, then no, let them do what they're comfortable doing. In general, asking a surgeon to do an operation that is not the way they normally do it is not a good idea, because whatever they're comfortable with will probably give you the best outcome for that person, for that surgeon. And surgeons do differ somewhat. Okay. Okay. Oh, Teresa says, don't laugh. I'm sorry, I laughed. Should I get my chin waxed before, or won't it bother it? Okay. This is tricky. So if you're just doing your chin, like here, it's fine to get it waxed. I don't want people doing a lot of stuff down here. This is where the incision is, kind of at the base. So getting the chin waxed, perfectly fine. Go ahead and do it. I would do it at least a few days, like not in the couple of days right before surgery, because we put the soap here, so that might, so if your skin's already irritated, this might irritate it more, because I'm going to clean all over. Like, I want everything to be kind of as clean as possible. So we clean all this. So if it's already irritated, that might irritate it further. So, do it a week ahead, not like the day before, if you want to get your chin waxed, but that's fine. Okay. Rosemary asks, do you check all 4 during surgery, even if only one is visible on scan? Yes, I do. And to hear more about this, please watch the other video. I go over this in great detail, because I can talk about this for hours. But yeah, no, I look at all 4. It makes a difference. When is PTH measured during the surgery, and when is it done with radio frequency? So you need to watch the other video. There is intraoperative PTH, radio frequency. I talk about this in ad nauseum in the other video for about an hour. So go and watch that. It is on my YouTube channel, which is, at Southwest Parathyroid. I'll put a link to that too. Okay. Allison says, recent labs post-op from 923, calcium is 9.6, PTH is 41, vitamin D 46. These numbers are perfect. These numbers are great. Question, how much did years of high calcium attribute to the minor stroke and total right ICA occlusion I had 5 months ago? Oh, hard to say. I mean, so the risk with high calcium, it does increase the risk of clotting and stroke. But that risk typically improves afterwards and gets better, and the risk of clotting goes down. So did it contribute that much to this? Probably not. Now, high calcium does increase arterial stiffness, which can damage things over time, cause high blood pressure. But how much did it contribute to it? I don't know, and we may never know. The risk should have come down a lot, though, since you had surgery, which doesn't answer your question because I still don't really know, but I can't say that it had a major contribution to it. Okay. Petya says, 10 months after surgery, 3 hyperplastic glands were removed. PTH immediately after surgery was 22. Now my calcium levels are 9.5 to 9.9, but PTH remains elevated at 65 to 90. Is this common with hyperplasia, and how long does it typically take for the PTH to regulate? So what's going on here is, yes, your calcium is normal, but your PTH is just a little bit above normal. This looks like, especially if you had really high calcium levels beforehand, before surgery, and now your levels look like this, typically what this is a mild secondary hyperparathyroidism. So the first thing to do is to supplement or increase your supplementation. So, calcium and vitamin D, make sure you're taking those, because a lot of times right after surgery, that PTH may still stay elevated because your body needs more calcium, basically. So I would assume right now that you just need more calcium and vitamin D, and I would try that first. To bring the PTH down. Now, if your calcium goes above 10, goes above 10.0, that may mean you need further surgery. But for now, I would assume it's probably a mild secondary, and your PTH will come down if you supplement. Okay. Oh, Heather asks, how many weeks before the dormant glands wake up? Usually it's in the first 2 weeks. It can take longer sometimes. Sometimes they're a little slower, but in general, usually even within that first week, your PTH is going to start to rebound. And within a couple of weeks, your parathyroids are making enough hormone to regulate calcium appropriately. Now, I still recommend you take calcium. Even though your parathyroid glands are, functioning at that point, I still recommend you stay on calcium for about 6 months post-op. And that's mostly just to replace that calcium that's been lost from your bones, help with calcium regulation. Remember, you've had this high calcium for a long time. It's been taking calcium out of your bones. You want a little bit of time to replace that. Okay. Oh, Carol asks, can I swim after surgery? That's a good question. So you're going to have this little incision here, and the skin will be closed. And in general, it kind of seals up usually in about 24 hours. But I tell everybody to not submerge your neck either in a bath or a pool for about 2 weeks. The area is still healing. We don't want to introduce anything. We don't want to cause infection or get any of the stuff from the pool in there. So wait 2 weeks before submerging your neck. You can do pool aerobics if you're not submerging, but don't submerge. Okay. Teresa Buck asked about driving. So for driving, I tell people to just wait that day. I don't want you driving the same day as surgery because you've got anesthesia on board. You want to let that all resolve. But the next day you're able to drive. And one of the big issues is, can you move your neck around safely? You should be able to move your neck around safely. If you're in so much pain that you can't, that would be pretty unusual. Let your surgeon know. But for the most part, day after surgery, you can drive. All right. Okay. Donna says, is it safe to drive for 2 hours the day after surgery? I mean, you should be okay by that point. Because again, you're not taking narcotics. You're able to drive. I would just go by how you feel and take it easy. If somebody else can drive, that's even better. But I have people I have people do this where they just drive back home several hours the day after surgery, and they're absolutely fine. Take it easy, give yourself time, take breaks, just take it easy, but you can do it. Yes. Carol asked, do you talk to my endocrinologist after I'm home? So we do send records. So afterwards, the endocrinologist or whoever, if you just have a primary care doctor, they'll get records, or if you have an endocrinologist, we'll send them to them. We send the operative report and the pathology report as soon as we have those back. So we will automatically just fax those records to your doctors if you listed them in your form and you checked off that we were able to contact them. If afterwards you want the records for yourself, which actually I encourage people to do, but if you want those, you just let us know. You'll have my email. Again, you'll have a post-op email. You'll have that. You just email and ask for the records. We'll send you copies for yourself, and we'll fax them. If you have a new doctor you're seeing, you want them to get records, we'll fax them along. Paula asked, how frequently will I need to get labs after surgery? Okay, so I check labs at 6 weeks post-op. I typically don't check them before unless there are major issues that we're trying to figure out. But 6 weeks is usually when things have settled down. So initially, like I said, PTH drops, plummets, the calcium starts to drop a couple days later, then the PTH kind of rebounds and the calcium starts to come up, and things can look wacky in the first few weeks. By about 4 to 6 weeks, things have settled out. So I tell people 6 weeks, get labs. That's when we check them. If everything looks great at that point, then you can go back to just checking them annually or however often you normally would with your regular doctors. If things are not normal, so if the calcium's still low at that point, the PTH is high, like a secondary picture, I'll tell you increase the calcium. We can recheck labs. It depends on how bad they look. But I was like, you'll recheck labs a few months from now, or 6 months from now, or whenever, and then I'll follow them until they're normal. And then you just go back to checking them annually as you normally would, or every 6 months, however often you normally get your labs done. Okay. Nana asks, what is the risk of cancer of the parathyroid? It's pretty much zero. Very, very close to zero. Parathyroid cancer does exist. It's extremely, extremely rare. I've only, out of the many thousands of cases, I've had 2. So it's not that common. Most times with parathyroid disease, it is benign, even if the levels are high. Now with parathyroid cancer, typically you are going to see very high calcium levels, very high PTH levels, but most of the time when you see that, it's just an old tumor. It's not cancer. So the risk of cancer is near zero. It does exist, but it's very, very rare. There are certain genetic mutations that can increase the risk, but in general, very rare. Okay. Andrew says, silly question. I know. Well, this is not a silly question, actually, Andrew. Will the surgery have an impact or risk on your voice? I mean, that's what everybody is worried about, right? We're always worried about changing someone's voice. And there are some famous cases of singers having thyroid surgery and then never being able to sing the same afterwards. Very careful with the vocal the nerves that control the vocal cords, because we don't want you to have a difference. With parathyroid surgery, like I said, it's a very rare complication. Most of the time you can just avoid the nerves and not have any change in the voice. But there are some other nerves too. There's nerves really high up along here, the superior laryngeal nerve, which usually we can just avoid entirely with parathyroid surgery. It's more of a risk with thyroid. But for the most part, if you've got a surgeon that's careful, even if you have a temporary change, it will resolve. Now, I'll also say that sometimes your voice can sound a bit different, even when there's no problem with the nerve. And that's because the muscles are moved around. So the muscles around the trachea, around the esophagus, in the neck, they're all they're stretched a little bit during the operation. They're irritated. They can swell up a bit. And that itself can make your voice sound a little bit different. It may just be for you. Sometimes patients, they don't sound any different to the people around them, but for them, they sound a little bit different because there is some swelling in the neck. It's changing your vocal sounds just a little bit, enough that you notice it, but not a lot of other people might not notice it. And singing might be a little more difficult because of that. But that typically resolves much faster. That's usually for a few days. Things are kind of sore and the muscles are healing, and that's going to go back to normal pretty quickly. So yes, there's a risk to your voice, very, very low risk. It's generally pretty rare. Okay, Jeanette says calcium is 9.3 and PTH is 182. Would I be a good candidate for surgery? Well, Jeanette, if your calcium levels are all in the low nines or lower, then that looks more like secondary hyperparathyroidism rather than primary. But if you do have calcium levels that are above 10 with a high PTH, then that would be primary. But as it is, if your calcium's 9.3 and it tends to stay around there, with a high PTH, that looks more like secondary hyperparathyroidism, which is treated very differently. That's treated with calcium and vitamin D supplementation. So it has nothing to do with age, right? It's nothing to do with age. It's whether or not you have primary hyperparathyroidism or not. That determines whether you need surgery. Okay. Okay, then thanks for the information. Surgery's May 4th. Okay. All right. Don't second guess your decision. Good luck with the operation for anybody who's moving forward with surgery. And I think I got everything. I think I answered all the questions. And yeah, all right. So that's a pretty good time. We're a little bit after 6. But thank you to everybody who joined, and I will see you next month. And if you have more questions, you can post them here, or I will be posting this video on YouTube. And I do check the comments there fairly regularly, so I'll answer you on YouTube. It's often easier than Facebook for some reason. So if you have a question, if you have other comments on it, then post them there. And if you haven't seen it, watch the last video on parathyroid surgery. That's on YouTube now, and that covers a lot of the questions about the different types of surgery and why I do things the way I do. Okay. All right. Good night, everybody. Thanks for joining.